Hi everyone, Dania here. Very happy to be presenting my final project titled Intentional Non-Disclosure of Information or Deception in Clinical Studies. So we all know how important informed consent is in clinical studies. Intentional non-disclosure of information or deception can be used in clinical studies with the approval of institutional review boards, the IRB. In fact, IRB sometimes recognizes it as necessary for human research. So what do these terms mean? Non-disclosure is when information about the real purpose of or nature of the research is withheld from participants, whereas deception is providing false information to prospective participants. Either way, both may not be used in greater than minimal risk in clinical research. I focused on this case study, which was authored by Doctors McNagny and Parker, both physicians and professors from the Emory University School of Medicine in Atlanta, Georgia. This was a peer-reviewed article published in JAMA 1992. The purpose of the study was to study the prevalence of cocaine use among patients seen at an inner city hospital clinic and to determine the validity of self-reported cocaine in this population. However, patients were not informed of the true purpose of the study and were recruited for a study on asymptomatic carriage of sexually transmitted disease in the population. Unaware to the patients, their urine samples were not tested for STDs but for cocaine metabolites. Both the STD study and the cocaine study were approved by the Emory University School of Medicine Human Investigation Committee. Let's look at the methods used. So between August 1989 and February 1990, weekday patients visiting the ED at Grady Memorial Hospital were recruited for the study. The informed consent was for patients participating in a study on asymptomatic carriage of STD and to test urine samples for STD pathogens. There were some inclusion and exclusion criteria as seen here. 82% of the patients agreed to participate. That's about 419 patients. The study population was predominantly African American descent and had low-income backgrounds. The patients were also significantly older and had a lower rate of insurance coverage compared to those who refused to participate. So basically, the study population was a vulnerable one. All participants completed a questionnaire administered by a nurse and gave a urine sample for urinary dipstick analysis. The collected urine samples were then tested for cocaine metabolites or benzylogonin using enzyme multiplied immunoassay technique or EMIT. A total of 415 urine samples were, and corresponding questionnaires answers were used for the study. The results were tabulated like seen here and statistical analysis were done. So the urine samples results were compared to a number of patient characteristics and tabulated accordingly. A comparison table to compare urine results to admitters and deniers for cocaine use was also done. The participants in the study averaged about 30 years of age and were all male. About 92% of them were African Americans and 89% were uninsured. 39% of the urine samples were tested positive for a major cocaine metabolite in their urine. Among those who tested positive, 54% denied any illicit drug use, whereas 45% of them admitted to using drugs. The researchers summarized a few points in this study. They found that cocaine use is endemic among young patients in the walk-in clinic, and there's a disproportionate degree of cocaine abuse among poor inner-city young Black men. Denial rate was 54%, but the self-report of cocaine use was higher in this study compared to a national survey. The researchers believed clinical history alone could not identify deniers, and general questions on drug use elicited more accurate answers compared to specific questions. In their conclusion statement, McNagny and Parker states that their findings underscore the magnitude of the cocaine abuse problem for young men seeking inner city uh, walk-in clinics, and the study confirmed the hypothesis that patient self-report is not a reliable measure of recent illicit drug use among this population. There are some important points to discuss about this study. Bushram and Childress in their book state that the researchers deceived the subjects about some aims and purposes of the research and did not disclose the means that it would be used. So the researchers believed, although it's not a reliable measure, self-reporting of cocaine use was the best bet to find if patients were cocaine users, as physical signs were limited. They sought to deception and intentional non-disclosure because accurate information on illicit drug use was a requirement for the prevalence study, and getting adequate informed consent was difficult. The study was done under the pretense of studying the asymptomatic STD carrier of this vulnerable population. The deception here is patients were told the urine sample was collected to test and study asymptomatic STD carriers among them, and the non-disclosure is the patients were not informed that the urine samples will be tested for cocaine metabolites. The study did find that more than half of the study participants denied cocaine use despite using it. The samples were not tested for STD pathogens or carriers. No intervention was used in the study. There was no direct harm done to these patients because of the deception and the non-disclosure, but the study finding supported that self-reporting of illicit drug use was less reliable. Although self-reporting during history taking is a major tool in clinical practice, the study design used was a survey with blinded comparison to criterion standard, but a cohort study using known cocaine users like patients at a methadone clinic or hospital settings could have been a better study design, or a retrospective meta-analysis of charts and specimens would have worked too. Other than that, variation in patient characteristics and larger population could have reduced several biases present in the study. Informed consent should have included true motive of the study while reassuring patient and data confidentiality. Many would have been fearful of social stigma, getting caught by authorities, or just simply unsure of the information provided. So this is the review of literature. At that point in time when the article was published in 1982, the study was one of the first studies to compare individual patient self-report of cocaine use with urine screening results when patients were unaware that their urine was being tested for illicit drugs. I reviewed the study using two other papers. They did similar studies on illicit drug use prevalence and the validity of self-report. One was by Zuckerman et al. In 1989, and the other one was by Weatherby et al. In 1994. Both studies did not use intentional non-disclosure or deception and had reliable results. So we've reached to the final slide here. This is my personal analysis of the case study and the whole concept of non-disclosure and deception in clinical studies. I think, in my opinion, in order to avoid being deceived of the accurate information from the study participants, the researchers used intentional deception and non-disclosure to obtain accurate responses. Is it justifiable in this study? Perhaps yes, for the short-term goal of obtaining accurate results, since there was no significant risk or harm involved. But the long-term impact on the reliability of an important screening tool like self-reporting, especially pertaining to behavioral assessment like drug use, I think not. Oh, to think they also made up a fraudulent study, the study of asymptomatic STD carriage, to conduct this study. that itself is a whole other ethical and legal issue. These are a list of the references I used for my presentation. Thank you all for watching and have a great semester ahead.